for organising. We had a bit of we had some tech issues last week, no, a fortnight ago, and it, for whatever reason, didn't seem to work. I think we had the audience on one call and the speakers on another, and never the twain shall meet. So apologies if anybody made effort to come a fortnight ago and it didn't work out, but we're in the process of rescheduling that session for the end of this series, which is in November, I think. So please, stick with it. We're going to try and get people back to talk to us, because we were excited about that session. It was a shame that it didn't work out. For those of you that don't know me, my name's Frank Swinton. I'm the climate change lead at West Yorkshire ICS. Without further ado, I am going to ask people who are not speaking, please, to make sure that they are on mute, and hand over to the mighty Artie, first of all, and then we'll come on to Matt later on. So Artie, it's all yours.
Thank you, Frank. I'm just going to share my screen and get the slideshow sorted. So hello, everyone. Thank you, Frank and Emma, for giving me a slot to talk about this. My name's Artie and I'm a GP in Sheffield. I also work a day in a week for Humber and North Yorkshire ICS as their net zero clinical lead. A few years ago, founded the UK's primary care sustainability network called Greener Practice, and I'm a member of the NHS England and Improvement Inhaler Working Group. And prior to doing this work, I was an academic, so I'm still an honorary senior lecturer at Hull York Medical School. So that's who I am. And what I want to talk to you about today is high quality and low carbon asthma care. And I very purposely have put both of those two things in the title together because they are so inextricably linked. And our moves towards low carbon asthma care are a huge opportunity to improving the quality of asthma care as well. So let's talk about the state of asthma care in the UK for a start. If you look at the bar chart on the left, you can see where we are in the UK right at the top compared to other European countries. And you'll see that at the bottom of the graph, it talks about age standardised death rate. So the UK has some of the worst death rates from asthma compared to the rest of Europe. And back in 2014, the National Review of Asthma Deaths looked at this and it estimated that 2/3 of the asthma deaths in the UK were preventable. In fact, it's, even 2/3 of patients in the UK are estimated by Asthma UK not to be receiving the basic care that they require. So that's the state of asthma care. And then in terms of the climate crisis, metered dose inhalers, which are the most commonly prescribed inhaler in the UK, also known as aerosol inhalers or puffer inhalers, they have a special category of their own that we're focusing on. And that's because they are 13% of the NHS's direct carbon footprint. So that's the emissions we directly control. That's the bit that we're trying to get to net zero by 2040. They're 3 to 4% of the entire carbon footprint. That's carbon footprint plus. So that includes all the things that we also don't control directly. And for that NHS carbon footprint, we're looking at an 80% reduction of emissions between 2028 and 2032. So very ambitious target. We've got quite a lot to do. Now, those of you who work in primary care will be aware that we have a primary care network direct and enhanced services, investment and impact fund indicators. So that's what all of those acronyms mean at the top. Looking to encourage primary care to both improve the quality of care and to reduce the carbon footprint of inhalers. So in terms of improving the quality of care, these indicators came in April. General practice is being asked to look at their asthma patients who may not be using their preventer therapy regularly. So that's their inhaled corticosteroids. What they've said is that everyone should have at least 3 of those steroid inhalers a year. So, I'm not going to talk about the thresholds, but that's the target. And then we also want to look at patients who might be using their reliever inhaler more than they should. So anyone who's using more than 5 of those inhalers a year, or otherwise written as 6 or more. So that's about improving the quality of asthma care. It's also about low carbon care, which I'll explain in a minute. And then specifically around the low carbon move, practices are being asked to look at inhalers that people are using for prevention and making sure that we're not using metered dose inhalers as much as possible. So trying to reduce the percentage of metered dose inhalers that are used, bringing us more in line with other European countries. I'll explain about that in a bit. And also to try and reduce the carbon emissions per salbutamol inhaler, salbutamol inhalers being the reliever, the blue inhalers that people use. So these incentives have come through in April. And hopefully will help encourage this move towards higher quality and lower carbon asthma care. So how can we safely and effectively implement these indicators? And there was a few of us who last year produced a guide to try and help clinicians with this work. It's a guide that has been through the NHS England and Improvement Inhaler Working Group. And there are basically 4 principles. Firstly, to optimise asthma and COPD care. Secondly, to try and use the low carbon inhalers, dry powder inhalers or soft mist inhalers as first choice when it's clinically appropriate. If a patient does need to use a metered dose inhaler, then making sure that we use the brand and the regime that is going to minimise the carbon footprint. And fourthly, to make sure that patients are returning all their unused or unwanted or used inhalers back to pharmacies. And in terms of doing this safely and effectively, it's really important that this is done with patients, focusing on finding what's right for that patient, that individual patient with them through a shared decision-making technique. We have to look at inhaler technique at every opportunity. We should be following patients up if we change their device, and we shouldn't really be doing any kind of blanket switching. So those are the principles. Let's now explain those principles. So let's look at optimizing asthma control. And I think it's kind of important here to just explain a tiny little bit about what we should be thinking about when we think about asthma. So asthma is caused by underlying inflammation of the small airways, the lining of the small airways. You get increased mucus production, which narrows the airway, makes it more difficult for air to go in and out. So that's kind of what's happening in the asthmatic airway. And then you have a trigger that comes along, maybe that's exercise or pollen or cold air, and the muscles around the airways contract. We call that bronchospasm. That's what causes cough, wheeze, shortness of breath, the symptoms that people experience. Now, once they've got that bronchospasm, they might need to use their blue inhaler for relief. But the treatment of asthma really is about reducing the inflammation of that lining, and that's through the inhaled steroid inhaler. And so we should really be aiming for all of our patients to have good control. And when we say good control, that's defined as no restriction on physical activity, no daytime symptoms, no nighttime symptoms. And in terms of inhalers, you would expect people to need at least 3, probably up to 6 preventer inhalers a year. This is depending on them taking regular doses. But you wouldn't really expect them to need that much in terms of reliever inhaler, because if they're using their regular preventer inhaler, that inflammation is staying down, they're not getting triggered, they're not getting symptoms. That's what we should be aiming for. So we should be expecting for our cohort of asthma patients that there are far more preventer inhalers used than reliever inhaler used. But this is what we've got in the UK in terms of inhaler use. And if you've got specific questions on this particular study, you can talk to Matt later, because he actually is one of the authors on this study. But now this doesn't just look at asthma patients, it looks at all of our patients, but actually the same could be said of asthmatic patients. In the UK, there are far more reliever inhalers being prescribed than preventer or maintenance inhalers. So 70% of inhalers prescribed are short-acting beta agonists. That's the reliever medication. Now, if somebody is using more than 2 blue inhalers a year and they have asthma, then they may have poor control. They may be over-reliant on their short-acting beta agonist, their reliever inhaler. That's called SABA over-reliance. And this study found that those patients who had SABA over-reliance weren't just using 3 or 4, they were using on average 6.5 prescriptions of their blue inhaler. And if you look at the usage and, you know, in terms of the quality of care, it's the same with the greenhouse gas emissions. So the vast majority, of the greenhouse gas emissions come from those reliever inhalers. And why is it that using too much blue inhaler is a problem? Well, studies tell us that the more blue inhaler people use, the higher their risk of hospitalizations and ED visits. So if you're using 0 to 2 blue inhalers a year, if you consider that the standard reference, then you've got double the risk if you're using 3 to 6, and that risk just goes up the more blue inhalers you use. The opposite is true if you're regularly using your steroid inhaler. The more regularly you use your steroid inhaler, the less likely you are to die of asthma. So what can we do? Now, one of the problems is that patients, there's been a lot of studies looking at how patients perceive their asthma, and patients actually don't have very high expectations of their asthma control. They don't expect to be fully relieved of their symptoms or have no limitation on their control. And so they'll often say that their control is good when objectively it might be considered to be suboptimal. And one of the ways that we can think about this is to move them on to what's called a MART regime, which is a maintenance and reliever therapy regime. So instead of having a separate inhaler for relievers and a separate inhaler for preventer, where actually what we find tends to happen, other studies have shown that the preventer inhaler isn't used that much. Asthma is a variable disease. People kind of think I'm well now. They stop using their preventer medication, but they tend to take out their reliever medication. So that's the one that gets used. Just give them one inhaler, which contains both drugs. I'm not going to go into the detail of the science, but basically it simplifies therapy, and it's been shown to reduce the over-reliance on the reliever medication. It's been shown to reduce the risk of severe exacerbations, actually lowers the total dose of steroid therapy, and it actually can help us move towards the lower carbon dry powder inhalers, as most of the inhalers that are licensed to be used in this way are the lower carbon inhalers. So as I've explained, in terms of poor control, you've got a problem with low adherence to preventer inhalers and over-reliance on reliever inhalers. You've also got an issue around poor inhaler technique. You know, the vast majority of patients actually when they're observed, making critical errors in their inhaler technique. And this sort of brings us to the low carbon element of it. So the second principle is offering low carbon inhalers as first choice where clinically appropriate. So many of you will have seen this diagram before. This comes from greeninhaler.org, and it shows you the vast difference between a metered dose inhaler and a dry powdered inhaler. The reason for this? Well, metered dose inhalers contain a propellant gas, which is a hydrofluorocarbon. These hydrofluorocarbons are approximately 1,000 to 3,000 times more powerful than carbon dioxide, which is why, you know, inhalers are such a huge disproportionate cause of the NHS's direct carbon footprint. And if you look at the prescription of inhaler devices across different countries, in the UK we use far more metered dose inhalers, which is the dark green, than in other European countries. So if you look at the bottom of that graph on the left, Sweden only prescribes 13% of its inhalers as metered dose inhalers, and the vast majority of the inhalers they prescribe are dry powdered inhalers. And then if you look and compare on the right, it's the same list of countries, you can see that there's no correlation between the type of inhaler that's prescribed and the mortality from asthma. If anything, there's a trend towards better outcomes with dry powdered inhaler, but there's no clear cause. So the most important thing we have to think about when we're thinking about whether or not in asthma a patient might be able to use or be moved to a dry powdered inhaler is whether or not they can use the correct inhaler technique for the dry powdered inhaler. So can it be used? That's the most important question that you should be thinking about when you're talking to your patient. And these different inhalers require very different techniques. So an aerosol or a metered dose inhaler requires you to take a slow and steady breath over 3 to 5 seconds whilst you're pressing down on the canister. That's really quite hard to coordinate that. So it's more of a, and I'm going to try and demonstrate this, it's more of a as you press in over 3 to 5 seconds, whereas a dry powdered inhaler is a quick, fast, deep breath. So it's a... Now, the thing about this is that the vast majority of people are using a dry powder inhaler technique with their metered dose inhaler. So I often find when I'm talking to my patients, when I ask them what their inhaler technique is, that's the point at which I sort of say, I think a dry powdered inhaler might be more suitable for you. It also has other advantages. So metered dose inhalers generally should be prescribed with a spacer device, which is like a plastic device that you connect it to. And the reason for that is because you then don't have to worry about pressing down and breathing in at the same time. You don't have to worry about that coordination element. But the problem is spacer devices are kind of bulky, they're tricky to carry around, and so they're generally not used. People don't really use them, and that can reduce the effectiveness of metered dose inhalers for some people. Whereas dry powdered inhalers, if you can use them effectively, you don't use spacer devices with them. The other advantage of a dry powdered inhaler is it has a dose counter, so you know exactly how much you have left, and that's really important for adherence, as I'll show later. But not everybody can use one. So the vast majority of patients with asthma will be able to use one, but a small percentage, so perhaps the very young, or if you've got severe disease or you're old, you might need that medication propelled in rather than using your breath to take the medication in. So we will need some people who still need a metered dose inhaler. What about patients' preferences? Well, this was a study which didn't actually talk to patients at all about the environmental impact of inhalers. They just gave patients a choice of different types of inhalers and asked them which one they would prefer to use. And when given the option, most patients chose a type of dry powdered inhaler. And I should probably say at that point that they've also asked patients whether they would choose an inhaler for environmental reasons. 12,000 patients were surveyed, and the vast majority would consider it. So it's not something we've been giving our patients choice about in the UK. We've just been prescribing them a metered dose inhaler. That's due to cost reasons back 20 years ago. And actually really should be offering them a choice, because a lot of them would choose it, and actually it might be better for them. What about those patients who do need metered dose inhalers? The third principle is choosing the brand and regime with care. So this graph explains that there are differences between metered dose inhalers. So your metered dose inhalers are all in the blue bars at the top. And you can see, for instance, the top two inhalers, Flutoform and Foster, they're both combination inhalers, but vast difference in their carbon footprint. And that's because the type of propellant gas that Flutoform has in it, which is more powerful than the propellant gas that Foster has in it in terms of greenhouse gas potential. Similarly, Salamol and Ventolin, they're both salbutamol or reliever inhalers, the blue inhalers, both got the same drug. They've actually got the same gas in them as well, the same propellant gas. The reason for the difference in the carbon footprint is the volume of gas. So Ventolin has much more gas than Salamol, and again, huge difference in the carbon footprint. And that's related to that fourth indicator that I showed you right at the beginning, which says that they're looking to reduce the carbon footprint of reliever inhalers, salbutamol inhalers, and part of the reason for that is this very big difference between Ventolin and Salamol. The other inhaler is called Aramir, which also has a much lower carbon footprint. But you can also see on the yellow bars that dry powdered inhalers have a much lower carbon footprint than any metered dose inhaler. And then there are other things that we can do. So talking about regime. So if a patient needs a metered dose inhaler, but they're stable on their inhaler, then we can look about how we prescribe that. So can we halve the number of inhalers that they use, halve the number of doses that they use, halve the cost to them if they pay for their inhalers, and therefore halve the carbon footprint? Well, that can easily be done by changing the dose of the inhaler. So if you're on a 100 microgram steroid dose inhaler, but you're taking 2 puffs of it twice a day, you could take a 200 microgram inhaler, 1 puff twice a day, and patients will obviously really like that. So the final thing in the principles was to ask patients to return inhalers to pharmacies. And the reason for this, we talked a bit before about how metered dose inhalers don't have dose counters. Particularly for reliever inhalers, this is really problematic because people don't know when their inhaler is empty. You can still have the propellant gas puff coming out, but no medicine in it. And so people are kind of estimating when their inhaler is empty. And this study, which was done in Scotland, showed that when they looked at the inhalers that ended up in landfill, 48% of them still had medicine in them. So there's quite a lot of wastage going on. And obviously, if those metered dose inhalers end up in landfill, then the gas is going to go into the atmosphere. Whereas if we can return them to pharmacies, then the gas can be degraded through incineration, which makes it much less powerful and reduces its global warming potential. So we need to think about that. There's obviously a clinical risk as well to not having the dose counter, as I mentioned before, because there's a risk that you'll be using an inhaler with no medicine in it, and that has been shown to be a problem too. So let's put this all together in a case example. This is a patient I actually saw a few months ago. So a female patient in her 30s. She has had on her problem list, I could see, a diagnosis of asthma since she was a child. And she actually came in with a skin complaint, but during the consultation, she mentioned that she'd been coughing through the night for 2 months. And the reason she mentioned this is actually because it was keeping her and her husband awake. She said, you know, I do find that if I use my blue inhaler, then that makes it better. And I am needing to use it most days, most nights as well. And I saw her in the winter, and she said that these symptoms always recurred for her in the winter, but in the summer she tended to be symptom free. When I specifically asked her about whether or not she was using her preventer inhaler regularly, she admitted to say, well, she did often forget it, and if she did use it, she only used it once a day, and she definitely didn't use the spacer device with any of her inhalers. So when I looked through her notes, I noticed she was on a very low dose of steroid inhaler. And this might have been explained by the fact that her birthday was in the summer, her therefore annual review was happening in the summer. And whenever the nurses asked her about her control, she always said, I have excellent control. You know, she was scoring 0 for all of the questions. But actually, the objective data was showing that she was overusing her blue inhaler, her relievers, and underusing her preventer inhalers. So I asked her to show me her inhaler technique, and she was doing that typical thing that nearly all the patients do, which is using a quick and fast breath, not very effective for metered dose inhalers, with her metered dose inhaler. So we had a chat, and I always talk to patients about asthma being an inflammatory condition and try and raise their expectations of what good control should look like. We talked about whether we should increase her ICS dose because I didn't think she was on enough preventer medication, or whether we should move to that combination inhaler, the MART regime, for simplicity. She actually wanted to go for a MART regime. She felt like she would prefer to just have one inhaler rather than 2. So we went through that, and I suggested that she try a dry powdered inhaler because it was suitable for her technique. It had a dose counter and didn't require a spacer. She was kind of happy to try that. So I followed her up in 6 weeks' time because I changed her device, needed to see how she was getting on. And actually, it was really impressive. She had a complete transformation. She wasn't coughing at all at night. And what she was really excited about was that she'd started going to the gym because she'd been trying to lose weight for a long time. But she had now found that when she was going to the gym, she wasn't getting any symptoms. And so her exercise tolerance had gone up. Objectively, you know, her capacity for breathing had actually increased quite significantly, and she told me she hadn't needed to use her blue inhaler at all. And actually, in that one case, we've achieved all of those 4 IIF indicators. So she's not overusing her SABA anymore. She's using her preventer regularly. So that's the high quality indicator sorted by a MART regime. She's on a dry powdered inhaler. And, you know, we've swapped her onto Salamol anyway for her reliever, which she's not needing to use. So where do you start with all of this? It's fair enough having the guidance. It's fair enough having a little bit of education. But is there any kind of guide that can help you to think about how we do quality improvement in this area in our practices, and where are the resources? So just want to let everyone know that over the last sort of 6 to 8 months, a group of us have been looking at how we can help people practically in general practice implement high quality low carbon asthma care, and we've come up with a toolkit. And within the toolkit we've got education videos, we've got loads of resources, and we've got step-by-step guides, we've got IT searches, you know, and we've tried to make it as simple as possible for people to do this work. And when we developed the toolkit, we actually mapped the opportunities for quality improvement, and we looked at the fact that actually There's opportunities when patients first present at the point of when we're wondering about whether or not they've got a diagnosis, when they need repeat medication, when they come for medication review, when they come for annual review, or if they've had a worsening of their symptoms and they might have had to come in for extra medication to us, or they might have even had to go to A&E. And actually the whole team is involved in this. It can't be just given to one member of the team. The whole team needs to be involved in improving the quality of asthma care. And as a result of that mapping, we've come up with projects, and these projects are divided into diagnosis, disease control, device choice and disposal. And so, for instance, with diagnosis, it helps you make sure that you've got a process for working out whether or not someone's got asthma, and that there aren't any lost patients who someone has queried might have asthma, but now are only, on a blue inhaler occasionally because they never went through the diagnostic process. For disease control, it's about making sure we're identifying those patients who are at particularly high risk of poor control, and we're optimizing asthma reviews, giving patients as much information beforehand. Device choice is integrating that disease control and device choice into that asthma review, and switching from the high carbon reliever inhalers to the lower carbon ones, and then letting people know about disposal, raising awareness. And within the resources, we've got, like I said, a lot of things in there to help people. I particularly wanted to highlight this video, which is absolutely brilliant. It's by Carol Stonham, who's the executive chair of the Primary Care Respiratory Society. And in this 9-minute video, she demonstrates that integration of high quality and low carbon asthma care and how you do that in an asthma review. But we've also got lots of tools, literally taking people step by step on how to, in their different systems, for instance, change the prescribing interval of SABA, or check to see how much people have had before. We've created leaflets, we've created videos, we've created SMS text messages. So we're trying to make it as easy as possible for this change to happen. I don't feel good enough to give people indicators. There's a risk it won't be done safely and effectively, and that's what we're trying to do with this toolkit. Is that enough? I would say no. It's not enough to have the indicators and the incentive. It's not enough even to have a toolkit. We also now, so for anybody here who's a sustainability lead, I want you to be thinking about this. We also need to think about how are we going to get protected education time for whole primary care teams to update their clinical and carbon footprint learning around this area. And then even that's not enough, I don't think. It's fair enough to educate them, make them aware of a toolkit. They also need quality improvement support, because it's fair enough giving people a resource, but there's also always going to be questions around how to use the toolkit. They might need support to do some of the initial work. And then the people who are going to do this work at general practice need time to do the quality improvement. You'll probably all know that clinicians across the NHS are barely struggling to get their head above water. So they want to do this work because it absolutely aligns with everything they care about, but they still need the protected clinical time to actually undertake this quality improvement. And then we need to look at system levers, so things like the formularies that tell people what to prescribe and make sure that they're highlighting the dry powdered inhalers as the first choice, and not the metered dose inhalers. So bringing those things into visual guides as well. Okay, I hope I haven't gone too far over my time, but thank you very much again for having me talk about this, and I'm happy to answer any questions. I'm just going to stop presenting now.
Thanks, Artie. That was absolutely brilliant, as always. And I think if it's okay by you, I'd like to get Matt on so that we can hear from him, because I'm aware of time. Matt, tough act to follow, but you're the guy. If anybody can do it, you're the guy. So straight over to you.
I don't know about that. It's always a joy and a pleasure to follow Artie, and honestly I could listen to you for 8 hours a day. It'd be like a whole Netflix series. It'd be fantastic and wonderful and brilliant. But I will do what I can, and I will make sure that we leave some time for questions at the end. So Artie has given a fantastic presentation about one of the clinical aspects of greenhouse gas emissions, carbon footprints that we in primary care are responsible for. And I'm going to talk about a bit of the other side of it, a bit about the non-clinical emissions. So I'm a GP in Yorkshire, been here for decades, but I also have been off and done extra qualifications and masters in environmental science and that side of things. And those who've heard me before know that I have to mention carbon in every single sentence that I say. So why do we even do this? Why are we talking about carbon? Why am I so passionate about it? And actually, it's because of the impact that it has on our patients and on our staff. We know that mankind is responsible for greenhouse gas emissions that are driving climate change, and they affect our patients, whether it be heat and air quality, which has effects on the on patients and their respiratory care, but all sorts of other things as well. So we do this for our patients, for our staff, and for our families. There is, so really from my point of view, what do our practices need to know? Well, first of all, we need to know that low carbon is the only direction of travel. There isn't going to be an option, there isn't going to be an alternative, that it's better for our patients, it's better for our populations, it's better for our practices, and it's better for us. It's what we strive to do. But there is this knowledge gap, and so when we ask people, they say this is what we want to do, or this is what we know that we need to do, but how do I do it? I'm passionate to do something, but what? And Artie's just given a fantastic case study and toolkit about what we can do clinically, and this is about some of the non-clinical stuff. So I think really the things that are most important is we need to raise that awareness. So there is training and toolkits available. There are things about carbon literacy, and I'll mention that very briefly in a moment. The next is that we need to know our number. We can't really improve things if we don't know what the baseline is, we don't know what the situation is to start with. And I want to give you some very easy tools to help you calculate what your footprint is for your practice. And then it's really important to turn those intentions into action. So it's great to have the thoughts and the ideas and the passion and the enthusiasm. What are you going to do with that? And it's the actions and it's the plan that's absolutely. And then it's about using our influence to tell other people and to show them what they can do as well. It's leading by example. So start with carbon literacy. What is carbon literacy? Why do I keep mentioning this as a baseline? Well, actually, if we know that the low carbon healthcare is the future, we need to understand what that means. And so carbon literacy is really both the awareness of what carbon costs of everyday activities, of running our service, of prescribing medications, but it's also that ability and motivation to do something about it and to reduce those emissions. Why do I keep mentioning carbon? If we remember back to our GCSE chemistry, it's an element that makes coal and diamonds. Why am I even mentioning this? Carbon is not the thing that we're actually worried about, even though it's the thing that we see in newspapers and on news reports and all the rest of it. Carbon literacy, or carbon, is really just a very shorthand way of saying greenhouse gas emissions. What it's really talking about is carbon dioxide equivalents. So Artie mentioned that there are some of the gases in inhalers are fluorinated gases. Fluorinated gases is one of the greenhouse gases, along with carbon dioxide, methane and nitrous oxide. And it's the combination of these which are greenhouse gases that cause global warming. They get shorthanded to carbon dioxide, and that gets shorthanded to carbon footprint. So when I say carbon footprint, what I really mean is total greenhouse gas emissions measured by carbon dioxide equivalents. That's a bit of a mouthful. And that's one of the things that carbon literacy goes into. When we start talking about what carbon emissions are, we really mean greenhouse gas emissions, how they can be accumulated and calculated into a total emission, a total footprint, and then what we're doing about it, how and why we need to reduce them. So within primary care, we can think of this in both clinical greenhouse gas emissions, and these come from medications, how medication is made and distributed, inhalers. The propellant gases in different inhalers is often quite variable, and as we've just seen. And the non-clinical emissions, the bits that we have to run our practices, the energy that we use to heat and to light the premises, the staff and patient travel to get to and from work, the services that we use to run our practices, whether that be IT and telephones or finance or insurance. It's the services that we need to have. And then it's also the procurement, the supplies, whether they be medical supplies or office supplies, and whether they be the equipment or the consumables. And roughly speaking, there's about a 60-40 split between the two of these. So about 60% of primary care and general practice emissions are clinical, and about 40% are non-clinical. And of course, I'm here, and I will go into a little bit of detail in terms of the non-clinical side of things. So that 40%, how could we break that down to be a little bit more detailed? Well, there's some work that was done over in Manchester. This is from some urban practices, and we can break those non-clinical hotspots and have a little bit of a proportion behind them. So energy is, and it depends on the size of practice, but is between about 35 and 40% of, or is responsible for between 35 and 40% of non-clinical emissions. Travel is about a third, and that gets split roughly equally between patient travel and staff travel. Again, if you're a rural practice, it will be a slightly different proportion. About a quarter or so is from business services. So this is the things that we buy in. Everything that we buy in as a practice has got an emission associated with it. So if we're buying in accountancy, for example, the emissions that the accountant creates, we're effectively buying a proportion of that when we buy their services, and so on. And then procurement is about 10%. Within the business services is actually waste. Waste for general practice is less than 1% of our emissions. And so recycling is better than some of the alternatives, but it is not going to be the thing that we can do well enough to get ourselves out of the climate crisis. So yes, do it, but don't think that that is where our emissions start and end, because we've got much bigger fish to fry. So that's an average of a number of practices in the sort of Manchester area. But actually, what I would really like anybody and everybody from primary care to be able to do is to know what their personal footprint is. And we can do that using a calculator that's listed at the top. And for me, if we don't measure it, or if we can't measure it, then we can't improve it. So clinically, we measure waistlines, we measure BMIs, we measure cholesterol levels, diabetes, all sorts of other things. And we then say to our patients, this is the things that we can do to improve that number. So actually, for the non-clinical carbon footprint, we need to be able to measure that number first and foremost. So this is a free calculator. You can go online whenever you fancy. You put your numbers in for your practice. It's anonymous. It's saved locally, which means that it's only saved on the computer that you put the information in. Nobody else ever gets to know about it. It's not, you know, a thing that you would share with other people unless you want to. And then you can track the changes, so that if you make changes in terms of your energy use, for example, you can reflect that in the calculator, and you can see what improvements and what lowering of that those emissions then become. So once we know what our numbers are, and as I say, this is something which is as quick and easy as it can possibly be. Once you know what your number is, what are you going to do about it? Well, same for that overweight diabetic or that asthma patient who's got poor control. Well, we need to then have a plan. So one of the things that we can then start to do is think about, okay, where are we at the moment? Well, that's our current footprint. That's in the left-hand column for each of these different areas, because the calculator's just giving you that number. And actually, we can see what we need to do over the next 3, 6 or 9 years between now and the end of the decade to meet the NHS net zero ambition target. So the NHS has got a target of net zero completely by 2045, but with an 80% reduction by the end of this decade. between 2028 and 2032. I don't need to go, I can go into details if you want, but basically over the next 8 years, we as an NHS are looking to reduce the greenhouse gas emissions by 80%. And so the practices can actually start to put together their own plan of what could they do this year or next year or the year after or over the next few years. Now, for me, this is not about doing more stuff. This is about what we do anyway, just doing it differently. And just in the same way as Artie has very eloquently pointed out that we still have the asthmatics coming to see us, we still ask about their control, we still try to improve their control, we're doing what we do normally. Well, this is the same, that actually we're changing the way that people might travel to the surgery, or the way that healthcare is delivered, or the way that energy is supplied, or the way that energy is used, or the way that goods and services are procured. So it's not that we're doing different stuff, it's not that we're doing more stuff, it's that we have our energy supplier has come to the end of its 3-year contract. We're going to be looking for a new supplier. We go for something which is 100% renewable rather than continuing our current supplier. So we still do the same thing as we would have otherwise done. We still shop around, we still have a look for what's available out there, but we just do it from a lower carbon approach. And so practices can then start to populate this, that you don't have to worry about the detail on here. It's just saying that there are lots of different options that practices can then take up, that they can then start to think about. And it's involving different people within the practice in the same way as improving respiratory care takes a team approach. This takes a team approach as well. And we can actually get to the end of the decade, and practices can actually end up with a much lower carbon footprint, greenhouse gas emission from them as a practice by making lots and lots of little changes to improve the running and the function of the premises. And then, of course, from my point of view, it's about telling other people about this. It's about saying we are doing a good job. And in the same way, I think that Artie's patient is a really powerful example of what can be achieved. And I suspect all of the clinicians on the call today will go away and say, wow, that was powerful, we can do that. It's because we've heard something that is really good. And so actually telling other people that we are concerned, interested, taking the climate emergency, taking our greenhouse gas emissions and our responsibility seriously can be really, really, really important. We have got great influence. And this is about telling other people about the success stories and about the things that have changed and improved. The other is to just mention about this thing net zero. Again, we hear about this quite a lot. We hear about the and different people have got slightly different definitions of it. This is from the Science-Based Targets Initiative, and on the left-hand side, we've got the current state where we've got a huge amount of greenhouse gas emissions. So that is all of those different gases, not just carbon dioxide. And then we're trying to remove carbon dioxide with tree planting and peat and all the rest of it. And that's our current state. And actually, we're trying to get people to move towards the scales in the middle, where greenhouse gas emissions, and I'm being very careful not to say carbon dioxide emissions, greenhouse gas emissions, because they include the fluorinated gases and the methanes and other things, are then being balanced by carbon dioxide removal, because we can't remove fluorinated gases from the atmosphere. We can't remove in the same way, we can't plant a tree that will remove the propellants, for example. So we have to try and get this balance between the emissions from all greenhouse gases with those that can be removed from a carbon dioxide point of view. So this is where the net zero and the net zero ambitions of the NHS comes in. I will put in the chat, there is a walkthrough video for people to watch on the carbon calculator, so that you can work out exactly how long it's going to take. Some practices do it in 5 or 10 minutes, other practices take an hour, but it's there and it's a useful exercise. There's a whole host of other resources. You are not alone in doing these things. Artie's already highlighted that the greener practice has got a huge amount of resources, but there's a whole host of other places as well. So I will put in the chat the link so that people can go and watch the video as they want, and the link to the calculator so that people can measure their own personal practice carbon emissions. And along with Artie, more than happy to answer any questions that people want to throw.
Oh, amazing. Thank you very much, Matt. It's always an absolute pleasure to listen to you guys talk. Such brilliant expertise and knowledge in the room. There's been a couple of questions in the chat, which I think probably you could both take, but Nicola Ralph has asked which Mart inhaler is your first choice. Artie, do you want to take that?
So I think it depends on what in your region, what type of inhaler you've gone for in your formulary. So what you want to do is minimize the device type change that you're going to have to do if somebody's going to go for Mart. So if in your region they're going for an easy haler, then I would choose a Mart easy haler. If in your region they're going for a turbo haler, then I'd go for the turbo haler. It's not because one is better than the other. It's just that I think it should sort of make it as easy as possible so that when you've got the patient on your dry powdered inhaler, say they're on a middle dose of steroid inhaler, you're wanting to go to the next step, you don't have to change the device at that point if you're going to move them to Mart. I mean, there are really detailed things that you might want to think about for your patient. It would be great if you could show them all the inhalers. I mean, the patient needs to know what's convenient and helpful for them. And there are some differences between resistance. So some inhalers have lower airflow resistance, so are easier for people to do the inhalation. But yeah, I generally, as a general point, just say go with whatever's on your formulary.
Thanks, Artie. And then maybe one for both of you. Deborah Howe has asked, are there patient resources in different languages, easy read, audio?
So asthma UK is currently in the process of creating lots of patient resources for this area. And I think they have specifically been tasked to look at resources that are going to reach hard to reach groups. So I'm hoping that they should be easy to read, and I'm hoping that they are going to be in different languages. The other thing that we've literally just done at Green Practice that hasn't actually gone onto the toolkit, we'll do in the next few days, is we've created a couple of animated videos. So I showed you some infographics which are really quite packed and detailed, and I can understand where that question might come about, you know, we need sort of slightly easier to read resources. So these videos are going to be much easier, I think, for patients to access the information. They're about 3 minutes long, but I'm hoping they're going to be translatable as well. So if we can get the right people involved, then hopefully we'll be able to translate those videos into lots of different languages. I know there's a consultant in Yorkshire who's very keen on this area, so I'll be collaborating with her. But hopefully Asthma UK will be on the ball with this as well.
Amazing, thank you. And then Matt, maybe one for you from Emma, who's asked, how do we make sure that practice managers increase their awareness so that the GPs can focus on clinical carbon sustainability and the responsibility for non-clinical carbon can be managed by others?
Great question. There are I've just done carbon literacy training for a whole CCG. So the CCG asked at least 2 members of every practice to become carbon literate. So suddenly it meant that there was this sort of, groundswell of not just in one practice, but in all of the neighbouring practices. Suddenly it meant that it was a topic on everybody's lips. And, whereas you may have an answer to, or, the way that you've tackled one particular area or issue, it means that you've got this sort of, small community, this this group of people who are all trying to work towards the same thing. I think when it comes to responsibility, actually, we've all got responsibility for what we do and how we use it. So, for example, there was a practice who started what they termed an electricity responsibility plan. And what they basically meant was that if you're in your clinical room, at the end of the day, you are responsible for the electricity that's used out of hours. So you're the one who's there to turn off the kitchen equipment at the wall. You're the one who's there to make sure that the lights are off. And they saved themselves over £1,000 just by turning the stuff off. The things that we tell our teenagers to do anyway, turn the light off. Well, even in practice, the clinicians needed to be reminded of this as as part of their responsibility. I suspect that all of us can walk around our practices at 6:30 when all of the non-clinicians have gone home and go, look at all of this stuff that is just left on. Well, there's no patient benefit from that. There's no practice benefit from that. The only people who are benefiting is the energy company, because we're sending them more money each month to pay the bills. So actually the responsibility for sending money to businesses that aren't benefiting any of the patients, I think is all of ours. So I think that so at a CCG or an ICS level, actually having incentives across wider incentives, so that staff are educated and offered, or in inverted commas requested, to go on these courses. Incentivizing, actually we want to know how much energy different practices are using, or what the footprint, the non-clinical footprint is, in the same way as we've got the data for which practices and which areas are prescribing more or less of different types of inhalers. Actually CCGs can incentivize, do your carbon footprint, send us the results, we'll tabulate it, and we will give those who need most support additional support to be able to say, did you know your neighbour's doing this so much better? I wonder what they're doing that that you could might be able to copy as well. So I think that there's a whole host of different ways, but in the same way as Artie was saying, some of this is about time. For me, I think some of it's about recognizing what the options are, so that people aren't feeling that this is an overwhelming burden, because goodness, we've got enough on our plates collectively at the moment. We can't really do more, we just do what we do but differently.
Yeah, thanks Matt. Go ahead, Artie.
I was just going to say, I think in the non-clinical carbon thing as well, there are some things that are better done at scale, and there are some things that are done individually. And some of the non-clinical carbon stuff, like switching to 100% energy providers, finding out whether or not you can use heat pumps, or getting information about the infrastructure to help people do active travel. I think we can really look at those responsibilities going to place or CCG level, so that someone is doing those contracts for practices at that scale, getting the best deal possible, and practices literally just have to say yes or no, because we do need to take some of that work away from practices and make it as easy as possible for them to sort of join this movement.
Yeah, thanks, Artie. And I think it's my impression that as the NHS transitions sort of away from the internal market that we've had for the last 15 or 20 years, and more towards a much more collaborative way of working between organisations, then that sort of thing should be easier to manage, I hope. Does anybody else have any other questions? Feel free to put them in the chat or jump in. And maybe while you have a little think about that, Matt, can I ask, one of your slides showed that the NHS carbon footprint is approximately 25 million tonne CO2 equivalent per year. Am I right? I'm dredging this up now. Am I right in my thinking that in order to be sustainable, really we need everybody to limit themselves to about a tonne of CO2 equivalent per year?
Yes, you're right on both counts. So UK, again, we can argue some of the technical stuff about, is what our total footprint is, but roughly 25 million tonnes for the whole of the NHS. Roughly 23% of that is primary care. So we are about 5.75 million tonnes as a primary care system. As an individual, our average carbon footprint in England is about 13 tonnes a year, about 35 kilos a day. For the planet to stay within a healthy temperature and not go down the route of sort of ever rising temperatures, everybody in the world needs to have a footprint of around 2 tonnes or less on average. So we've got a significant reduction to go, and we cannot sustainably consume our way out of this. So we can't just buy something that sounds like it's more environmentally sustainable. We have to do more with what we already have, not produce more stuff. And just on that as an example, so each of us, who are on screen at the moment, myself, Frank and Artie, our total carbon footprint between us for a year is 39 tonnes of carbon if we're the UK average. One new Volvo electric car is 42 tonnes. So if you say, I've got a Volvo diesel, I'm going to buy a Volvo electric, you've just blown 3 years worth of your carbon emissions. So you don't get to eat anything or heat yourself or wear clothes or anything for 3 years. Not quite. But what I mean is that we can't just buy something, you know, every single time we think that there's something else that's new and is a little bit better than what it used to be. So we have to be very careful. But yes, we have to get our emissions down as low as we possibly can.
Yeah, that's really helpful. Thanks, Matt. And you know, it's a sort of uncomfortable, ever nagging truth, isn't it? That every time we spend money, we're also spending carbon, and that spending your way out of this problem is like spending your way out of debt, isn't it? It's an absolute nonsense, actually, when you think about it.
Yeah.
We need to do things differently. Anyway, so does anybody else have any more questions or comments?
Frank, I was just going to say, I just want to put a slight positive spin on all of that, because that might sound really, really daunting. But if we sort of move back to the healthcare sort of service, I agree with you. You can't spend your way out of a carbon issue, but you can invest in the things that are going to actually reduce your carbon footprint. And for an ICS, your best money is going to be upstream. So your best thing is going to be trying to prevent the need for carbon in the first place. And the need for carbon in the health service comes from needing healthcare or inefficient healthcare. So these, you'll know that I'm quoting the 4 principles of sustainable clinical healthcare as Frances Mortimer has described in her framework. But it's a really, really good framework. And it helps us just think, actually, all of those things that we want to do to reduce carbon are exactly the same things that we want to do to improve public health. And within healthcare, you want to invest in primary care, not just for the non-clinical carbon footprint and the inhalers that we are responsible for and the prescribing that we're responsible for, but all of the things that lead from the fact that, you know, we're the gatekeepers to referrals, to investigations. If we can get people healthier in the communities, then we're going to reduce those huge carbon footprints that come from secondary care. So as an ICS, when you're thinking of where should we be investing, first the community level stuff, the public health level stuff, and then within healthcare, you should really be investing in primary care. You're going to get your prevention, you're going to get the cost savings, you're going to get the maximum carbon savings as well. And the most wellness from the communities. Yes. Absolutely. Which is, you know, what we should all be about. Brilliant. Thank you, Artie. So last 2 minutes, Matt, a question for you, I think, from Katrina.
Yes.
Well, there you go.
Yeah, how does it sit with air pollution? Absolutely. And this is where some of the trade-offs get more complicated. So, for example, 80% of journeys between 1 and 2 miles are done by vehicles. That's what we need to reduce first and foremost. If I had a choice of, you know, if I was, you know, dictator for life or dictator for a day, it would be to make people be more active for those particular journeys. That's, you know, it's the low speed sitting in diesel, you know, stop start traffic that is particularly harmful. If we could get more people being active, actually we could end up doing away with some of the vehicles. There's quite a lot of work going on in sort of town planning in terms of this thing called a 20-minute town, where everything that you would use on a daily basis is within a 20-minute walk or cycle of your house. So that's education and employment and the local shop. And then the things that you use occasionally, like a sports stadium or something else, can be further away. So this is one of those real difficult benefits that, or real difficult dilemmas, that one's bad, the other one might be worse in one area but might be a bit better in another area. And this is why there's no one answer that is going to fit all. If you are a Northumbrian, you know, a Northumbrian or a North Cumbrian sheep farmer and you need a 4x4 to get around, you need a 4x4 to get around and you know, to look after your sheep in the depths of winter. If you live in, you know, the middle of a city and you are driving, you know, half a mile down to the local shops in a diesel, that to me is where the problem lies. It's not that there's going to be one answer that that fits everyone. Personally, from a sustainability point of view, generally making something last longer is far better than trying to replace it, because otherwise you're trying to replace it every single year with something that is 0.1% better than the last version, and that just doesn't work as well.
Thanks, Matt. I'm going to stop you there, if that's okay, because I'm really keen that we finish almost on time. Thank you, everybody, for coming. Thank you very much, our speakers. We are back in 2 weeks' time. Well, I'm not back. Emma's going to be in charge in 2 weeks' time. And thank you all very much for your time. Have a great afternoon and a good weekend. Oh, there you go. Emma's put up. Oh, it's disappeared, Emma. So now I can't really see. Oh, there you go. 24th of June, from big to small, lessons from the Yorkshire and Humber Climate Change Commission in a fortnight's time. Thanks very much, everybody. Have a great weekend. Matt and Artie, that was fab. Thank you very much.
I was just seeing if Alexis was still here, but I think she's gone. I was just going to ask if she's over in Liverpool next week, but I don't think she is. I don't know if she is or not.
I am.
Oh, are you? Fantastic.
Are you? Oh, fantastic.
I'm well. I'm on call on Tuesday night, and then finishing my on call at 8 o'clock. I'm sharing a lift with somebody to Liverpool, having a nap in the car if I need it, and then I'm doing a session with the AHSN in the morning, and but I am around in the afternoon, and Hawaran's there both days as well.
Oh, fantastic. Yeah, Matt and I were sort of talking about maybe whether we could meet up. I'm only there on Wednesday, and at the moment I think I'm planning to leave at about 3:30 or 4. And my talk's half an hour, 10 to 10:30. So yeah, that'll be amazing if we could catch up.
Cool. Wednesday afternoon.
Yeah,
deal.
let's do something. Yeah.
Yeah, no, that would be fantastic.
Maybe we need a little NHS Confed WhatsApp group. I know we can delete it immediately afterwards.
Well, I don't have phone numbers for either of you, but my phone number is on the bottom of almost every email I send. So
okay, we'll send you.
Is that okay? Can I task you with that?
Yeah. No problem.
That'd be fab. It'd be lovely, even if it's just 20
minutes. Yeah.
I think
I don't think I've actually ever seen you face to face, Frank.
I don't think I've ever met either of you face to face.
Actually, Matt, have we have seen each other, haven't we? Have we?
I think it's one of these that I'm not quite sure. I'm
not sure we have. It's crazy because I feel like I know you both quite well.
I know. Well, likewise.
Face to face, but there you go.
Brilliant. Look, guys,
okay.
I don't want to hold you up. I'll see you on Wednesday. Thank you very much. As always, brilliant.
No worries. Take care then.
Have a great weekend.
Bye.